So today is the last and final session of the dermatology class. So today will be a continuation of the previous class where we discussed about malignant skin lesions and as well as some miscellaneous topics that I've put up from your MRCP part 1 and 2. These will be high yielding topics. So first, let us start with keratoacanthoma. So this is how the lesion looks. Just remember how it looks. So it can be an image-based question for you people. So keep this in mind. Keratoacanthoma is a relatively common low-grade malignant lesion that originates from the pilosebaceous glands, and it resembles squamous cell carcinoma pathologically. Most commonly seen in men, and they are more frequent in the middle age and do not become more common in the old age. Like basal cell and squamous cell carcinoma become more common with advancing age, whereas in this it's not like that. It is more common in the middle. Keratoacanthoma is again characterized by rapid growth over a few weeks to months, followed by spontaneous resolution over 4 to 6 months in most cases. So, how it starts? It usually starts as a solitary, typically like small lesion, has rapid growth, and most commonly it is self-resolving in 4 to 6 months. Lesions typically are solitary, benign, firm, roundish skin lesions with reddish papule appearance, like how I had showed in the previous slide. So they rapidly progress to a dome-shaped nodule with a smooth, shiny surface and a central crateriform ulceration or keratin plug. This is very important for you to remember. Shiny surface with central ulceration and keratin plug that projects like a horn. So you can see in this image, this is how it looks. So features, usually it is a volcano or crater appearance with central ulceration. Usually starts as a smooth dome-shaped papule, rapidly grows to form the ulcer and the keratin plug. Treatment, usually it has to be referred to dermatology because it is a pre-malignant lesion. Spontaneous regression of keratoacanthoma within 3 months can be seen. Like I said, 4 to 6 months it can be self-resolving. And in case it is difficult to exclude from a squamous cell carcinoma, urgent excision of the lesion should be done. And removal of the lesion can also prevent scarring. Otherwise, this lesion can leave a very big scar. Next is actinic keratosis or solar keratosis. This is a common pre-malignant skin lesion that develops as a consequence of chronic sun exposure. Less than 10% of actinic keratosis usually progresses to invasive squamous cell carcinoma. So this is also a pre-malignant lesion. What are the features of actinic keratosis? The lesions are usually small, crusty, and scaly. They can be pink, red, brown, or they can also be the same as the skin color depending on the skin tone of the person. Usually seen, most commonly seen on sun exposed areas, for example, temples, arms, forearms, and usually they are multiple, they are not solitary lesions, whereas keratoacanthoma, they are solitary lesions. So, how do you manage a patient with actinic keratosis? Usually, sun avoidance and usage of sunblock creams are essential to for the prevention of further risk. Topical fluorouracil cream can be used. Usually, a 2 to 3 weeks course is prescribed. The skin can become red and inflamed sometimes because of topical steroids. So, because of the fluorouracil, so topical steroids can also be given along with it to settle the inflammation. Next is topical diclofenac can be used for mild actinic keratosis, moderate efficacy, but it has very fewer side effects compared to the fluorouracil cream. Next is the topical imiquimod, which can also be used. And if we are planning to excise the lesion, cryotherapy, curettage, or cauterization can be done. Next is again a very, very important topic from MRCP point of view. It's malignant melanoma. So it is nothing but a malignant proliferation of the melanocytes. Melanocytes are positioned in the basal layer of the epidermis, and melanoma is the third most common skin cancer after squamous and basal cell carcinoma. Up to 20% of the patients develop metastatic disease. So, how do you differentiate whether it is a benign mole or a malignant melanoma? Remember the mnemonic A, B, C, D, E. So, if these features are present, then it is better to rule out malignant melanoma. A for asymmetry, B for border irregularity, C for color variation or variegation, where the pigmentation of the lesion will not be uniform, there will be multiple colors in the lesion. D will be diameter of the lesion, which is more than 7 millimeters, and evolution, evolving size or change in the characteristic or color very rapidly. Okay, so remember this ABCD mnemonic. This has to be ruled out to see whether it is malignant or a benign lesion. Next will be the prognostication. So, invasion depth of the tumor, that is the Breslow depth, is the single most important factor in determining whether it is determining the prognosis of malignant melanoma. So, the thickness again, if it is less than 1 millimeter, then the 5-year survival rate will be 95 to 100. 1 to 2 will be 80 to 96. 2.1 to 4 millimeters, 60 to 75, and more than 4 millimeters will be 50%. Just remember, less than 1, the survival is very good, 95 to 100, and more than 4 millimeters, the 5-year survival rate is only 50%. Okay. So this is again the ABCD, where you can see in a normal skin how it is symmetrical, whereas malignant melanoma it will be asymmetric. Borders are irregular. There will be multiple color variations. Diameter will be more than 7 millimeters or 1/4 of an inch, and there will also be evolution of the lesion, very like rapidly progressive lesion. Next is lentigo maligna. Lentigo maligna is a type of melanoma. It typically progresses slowly but may at some stage become invasive, causing lentigo malignant melanoma. So lentigo malignant melanoma occurs on sun-exposed areas, usually the face, and most commonly seen in elderly patients. This is a variant of malignant melanoma. Other types of malignant melanoma, acral lentiginous melanoma, it is usually seen on the sole of the foot and occasionally on palms. It is characterized by raised darker area surrounded by a paler macular area, which is the lentiginous area, and may extend for several centimeters around the raised area. Periangual melanomas can be seen at the nail bed. Hutchison sign is again a very important sign, where brown pigmentation of the nail fold usually points to periangual melanoma. Superficial spreading malignant melanoma is again the most common type of malignant melanoma, consisting of irregular brown, black or blue-black lesions with some intermingled inflammatory area. And next is nodular melanoma, which is the most rapidly growing and aggressive variant and may contain relatively little melanin pigment. So the varieties are acral melanoma, superficial spreading, nodular, lentigo malignant melanoma, and periangual malignant melanoma. So these are the different types of malignant melanoma. So moving on to the next topic, systemic mastocytosis. So it results from a neoplastic proliferation of the mast cells. Okay. So what are the features? Commonly seen are urticaria pigmentosa, which produces a wheal on rubbing. This is also known as Darier's sign. So this is the classical sign of systemic mastocytosis. Remember, Darier's sign is classical for systemic mastocytosis. In your exam, you can be asked what is the most typical sign of systemic mastocytosis, then you will have to remember it's Darier's sign, which is nothing but a wheal which appears on rubbing the skin. Next is flushing, abdominal pain. Monocytosis is usually seen on evaluation of the blood film. How do we diagnose this condition? Raised serum tryptase level as well as urinary histamine. So these two are the diagnostic tests to confirm it as systemic mastocytosis.